first one I was going to talk about ultrasound disc, especially for a New York crowd. Everyone that I was talking about this outside the state all assumed that I was going to be standing in an area that I wouldn't show you on the slide. But I was thinking about what I can speak about to an audience of, I'm going to start handling here now, just so you know, about savvy ultrasound enthusiasts, right? Because when we're speaking to a group of residents, it's very different than the high-yield ultrasound that I would maybe describe to someone who's in the latter part of their career that didn't learn much ultrasound during their residency. So, initially when I was thinking through what are the high-yield ultrasounds that I use every day, they're IV access, right? Who uses ultrasound on a nearly daily basis to place an IV in the department? Who's looking at a heart or a lung on almost every shift? All right, who's excluding ectopic pregnancy doing pelvic ultrasounds? All right, everyone else is sick of raising their hands. Who's sick of raising their hands? So I decided, I was thinking through, and I was speaking with a bunch of folks in the community as well, and I was trying to think of ultrasounds that you might have to do, but that are underutilized. So I'm on Twitter at Bret Nelson, by the way, which is a great way to reach me whenever you have questions today or 6 months from now. So I decided to talk about DVT because I think that is a thing that we all sort of cognitively know how to do, and it seems like that's the one indication that we talk ourselves out of a lot or we don't wind up practically doing in our departments. So how do we do this? The basic way to do it is compression. Right, and there's a 2-point compression technique, right? Common femoral vein, popliteal vein. And the other point of this slide, aside from us remembering common femoral vein, popliteal vein, is that when you search for compression stocking on the internet and you're trying to get a good picture, you wind up with really weird images. And this was among the least inappropriate pictures that I could find. I wasn't aware that this was a fetish. The person, and this picture comes from a website that sells medical supplies, so like catheters and crap, right? But all the pictures, for some reason, on this particular website, I'm not sure who's doing their advertising, of compression stockings, are all people who wish they were in a different catalog. And having a hospital bed in the background didn't make it any easier on the eyes. It's very confusing to me. So let's just get past this. And just for anybody who's at Sinai, if I get dinged for like just cruising inappropriate sites, it's this stuff. I swear. So is this good enough? Can we simply just do 2-point compression? And the 2-point compression technique comes, like many things in ultrasound and emergency medicine, from Mike Gladys. And Mike Gladys published one of the first reports of this, looked at over 100 patients, had a bunch of patients with DVT, and he'll tell you in person, because he speaks about this all the time, he only had 1 false positive and 1 false negative, but he vehemently disagrees with each of those because on follow-up it turns out that he was right. So the idea is that this seemed like it was pretty accurate, and if all you did was compress the common femoral vein and compress the popliteal vein, you'd be pretty good. So what is this based on? Well, there's an older study, getting back to 1993, in the internal medicine literature, where they looked at all comers who had DVT ultrasounds and where were they positive. So if we looked and mapped out all the positive DVTs, we had a lot of patients that were in the popliteal fossa, superficial femoral, the whole leg, or just common femoral. So at first it would seem like they mapped all over the place. But if you want to be a little stricter about your definitions, if you just looked at the common femoral vein, and you looked just at the popliteal vein, so just those 2 spots, you catch them all, right? So this is pretty good. It's very reassuring. It leads you to this warm, fuzzy place. But Ruben Strayer doesn't like you to stay in a warm, fuzzy place very long. Ruben Strayer will come around and tell you that things are not as they seem and just ruin things for you. So he publishes a study, along with some other folks from Sinai, about a patient that we all remember about who had a fatal pulmonary embolism after serial negative ultrasounds. Negative 2-point compression in the emergency department, negative ultrasound in the radiology department, came back with continued symptoms, got more ultrasound studies, got a PE study, all this stuff was negative, and we still got dinged. I don't know what we can learn from this, because every possible test was done on this patient, but it shows us in general that this is one of those scary articles that shows us that we could be wrong. And then Srikar Adhikari from Arizona just piles it on, right? Takes the scare tactic and makes it into something very rigorous, very evidence-based, because he's really good at this, and looks at almost 2,500 duplex sonography studies. These are done by radiology, right? Meaning that they are comprehensive examinations. 362 DVTs. So would we have captured the ones that we do with point of care 2-point compression? Absolutely, all the common femoral vein ones, all the popliteal vein ones. But almost 6% of them were isolated femoral vein, meaning somewhere in a segment between the popliteal and the common femoral that this technique would have missed. We don't love to miss 6% of anything. And then 16% were isolated calf veins, which is maybe a whole other argument. Out of curiosity, who treats calf vein thrombosis with anticoagulation? Oh, sorry, you can raise your hand. No? Okay, so who doesn't treat those? So maybe they just get follow-up, right? So, okay, and everyone else is thinking about coffee, that's okay. The other thing about this is that debate nationally, right? So where I work, and I won't, it could be either institution that I work at, the radiology department does not by default look at the calf veins because they, in a consideration of all the literature on this and the outcomes of patients, don't consider a calf vein thrombosis to be a classic DVT, one that puts you at risk of pulmonary embolism. Now, if you have a patient you're specifically concerned about and you talk to the attending and you ask them to look at the calf veins, well, then they'll still say no. So they just don't do it, right? But there are some people who think that you should anticoagulate these because a percentage of them propagate to DVT, which propagate to PE. And there are other people that feel like you're getting a calf vein DVT every time you fly to Vegas and back in coach class. So this is just a natural process of forming clot and getting rid of clot, and a healthy person doesn't need to worry about it. But this is important to note that 2-point compression might miss stuff, and what do we need to do about it? So for me, and I think a lot of other folks that are interested in ultrasound, what it means is it informs our technique a bit. And we probably, most of us, go beyond a classic 2-point compression technique when we are looking for DVT. So what are you going to need to do for this? You need some linear probe, high frequency, small parts, whatever you call this probe. And you're going to start at the common femoral vein, and that's the first place that you're going to look. What's wrong with this picture? It's not high enough. I hear some people saying, that's as high as my models are going to go, right? I'm involved in the residency core program. This is as high as I'm getting on anybody's leg with witnesses, okay? The other thing is, when you think of the probe. No, I mean, I had witnesses. So the other thing is how you hold the probe. Like, you don't hold the probe like a dead mouse. That's just not cool. So when you get in there, you really need to look right in the inguinal crease because that's where common femoral vein is. And if you get high up enough in the thigh, you're going to see common femoral vein, common femoral artery, and if you're high up enough, you should see the greater saphenous vein coming off. If you're not seeing this anatomy, you're not high up enough, and you'll miss some clot that you'd otherwise be able to pick up. So you should see two vessels, right? Femoral vein, femoral artery. With compression, you see the femoral artery squishes a little bit, but it doesn't fully collapse, and the vein fully collapses with compression. That's the basic collapsibility, okay? Move down a little bit lower, and the artery has already bifurcated. The vein has not yet bifurcated, so we're looking at the superficial femoral vein, and then here's where I just track it down, okay? So follow the vein, compress it, follow it a little more distal, compress it again, a little more distal, and keep going. Basically as low as I can, as distal as I can, until it disappears into the abductor canal. So this way I'm getting more than just a simple 2-point compression, and I'm starting to get some of those segmental DVTs that I would otherwise miss. Then into the popliteal fossa, where you should see artery and vein. The vein is going to be superficial to the artery. This one is usually a little trickier to find. We're pretty good at finding pulses in the femoral region. It's a little trickier to find pulses in the popliteal region. One of the things is, at first, I make sure I'm not putting too much pressure, because it's really easy to collapse the veins, and with too much pressure, you'll miss it. And then if that doesn't work, I just do the opposite. I deliberately put too much pressure, and if I put too much pressure, I'm going to start to see the artery pulsate, right? So at first I'm starting off with the edge detectors, looking for contrast differences, right? My retina, I guess, is what's working on that. And if I can't see that contrast difference, I put the pressure to start to see movement, and then the motion detectors in my brain are starting to look for stuff. You're basically just helping yourself find patterns, right? Once you find the artery pulsating, gently pull pressure off, and then that will reveal the artery. This is true, the vein. This is true, by the way, when you're looking for peripheral veins also. Anytime you're looking for a vein in the body, there should be an artery near it, especially if you're looking for one of the larger vessels. So this is a technique that I find helps me for DVT and also for venous access. So again, I'm not going to expect that you can see this, because I can't even see this from where I'm standing. That's why I put an arrow. Artery, vein, and then it collapses, you don't see it anymore. Oh, that helps. So when the red circles stay, but the blue circles go away, then your patient does not have a DVT. And we're looking for full collapsibility here, right? See that? Fully collapsible, wall to wall. And again, what's typically going to happen is you're going to see the arteries pulsate, the veins collapse. Helpful for DVT, helpful for peripheral and central venous access as well. If you think something is a vein, it should collapse before the artery does. And if you think something's an artery, it should start to pulsate. So there's a characteristic pattern under pressure that these vessels are going to exhibit. So here you can see some pulsation, which is how I'm finding the popliteal vein. It's sitting on top of the artery. There's the artery, there's the vein, it compresses. You might see in radiology that they seem like they're measuring the vein, right? So you put calipers across the vein and the calipers again. They're not really measuring the vein. What they're doing is they're just marking it, because it's very hard to tell when you see several circles and then only one circle which vein was which, right? So, and they don't all come with the A inside of them. So when they're labeling it, you can do this for yourself. It's helpful to just map out how big that vessel is, not for measurement, but just for identification. So one thing that we usually don't talk about in terms of point-of-care ultrasound, because it's supposed to be two-point compression simple, or even if it's further compressions across different areas, it's supposed to be pretty simple. A lot of us do add a bit of Doppler. We add something called augmentation, and augmentation is the concept that if you squish the vein, it's going to augment venous return. You're helping the venous return along. So normally you have flow through the vessel, and if you put pressure down on it, it's going to increase the amount of flow coming out the other side. Okay? When you have flow coming into the vessel, you put pressure on it, you don't increase the flow out the other side. That means that there's some clot in there which is obstructing the flow, getting in the way of the Bernoulli equation. Most of what gets in the way of the Bernoulli equation is we don't know what that is, right? But the point is, when you squish the vein, it should go, right? And if instead you squish the vein and nothing happens. Sorry, Professor, who has to use the microphone next? It's like a bad, like open mic night at the stand-up comedy club. Just spritz it. So anyway, the next, when you squish it and nothing happens out the other end, that's a sign that there could be a clot. There's another sign that could, and this is what it looks like when you actually map it out with spectral Doppler. Okay, this is the point at which the calf vein is compressed. So when that's normal, that means that everything from the point of compression up to the point where you're looking at with ultrasound is normal. The other thing is something called phasicity, and that means when there's changes in the intrathoracic pressure with the respiratory cycle, like breathing, there should be changes in venous return, okay? Increases in flow and decreases in flow that are respirophasic. When you lose that, when the patient's breathing and there's no respirophasic changes, again, that means that there could be a clot which is buffering out those changes. So you may have seen, and what that means is that the area proximal to where you're looking with ultrasound might have an abnormality. So if you're in the common femoral vein and loss of respiratory variation, it means that there might be a clot in the iliac vessels or in the IVC. And you may have seen a radiology report that says normal compression, normal augmentation, loss of phasicity or loss of respiratory variation cannot exclude a more proximal clot. You know? So again, this might add a little bit, even in the radiology literature, there's a minimal benefit to this beyond the compression. And I would say if you take anything away about changing maybe how you do DVT studies, is do more compression. Try to see as much of the vein as you can. Around the popliteal fossa, going distal and proximal as much as you can, and around the femoral crease, following that as distal as you can. That'll give you as close to whole leg sonography as we're going to be able to get at the bedside. Augmentation, respiratory variation are kind of extra, and they don't actually take very much time. Typically, once you've done a few of these, this is a little bit of respiratory variation, by the way. There's a little bit of respiratory variation. Once you've done even 5 of these, it becomes pretty straightforward. The bulk of it, like anything else that we do that's a procedure, is getting the patient in the proper position, and that can be challenging. So So now, there's a couple other things we should look at. So we've got a vein that collapses, we've got an artery, and then we've got this other thing that's not collapsing with compression. This structure went away. So what could this be? We're in the femoral crease. It could be a clot. I'm hearing a little clot DVT, right? Because it's not compressing and there's echogenic material inside of it. What else could it be? Lymph node. Yeah, exactly. Why would I bother to make sure that I know really well what lymph nodes look like, and especially abnormal inflamed lymph nodes, if I'm worried about looking for a DVT? Well, it's in the differential pretty frequently for a large, swollen, painful leg that it's going to be cellulitis, lymphangitis, some infectious process versus DVT. So realizing that you're going to see pretty frequently an inflamed lymph node it's a common thing. This isn't like a unicorn that you're going to wind up seeing. So one of the ways that you can tell the difference is a lymph node is going to be like a little grape, right? And if you scan past a grape, it's going to disappear in either direction. And a clot is going to be like a tube, and a tube is going to persist in either direction. So if you scan back and forth across this echogenic clot-like material, and it keeps going and it propagates in one direction or another, maybe it is a clot. And if you're scanning past it, it disappears, probably a lymph node. That's maybe the easiest way to tell, aside from just the anatomic placement of nerve, artery, vein, empty lymphatic that we learned. So here's another example. We've got the vein here. You see there's some echogenic material inside of it? Yeah, so the person looking at it didn't stop there. They put some pressure on it, and does it fully collapse? No. Here's another review of the popliteal fossa. Look how hard that artery is beating, right? So there's a lot of pressure being put on that popliteal fossa, and the vein is immune to it. So the vein's not collapsing, even with enough pressure to cause the artery to get pretty angry. Here's another example. Angry artery, vein not collapsing. Okay, so all examples of DVT. Here we can see again some echogenic material inside the vein, and with compression there's no collapse. So I'm showing you a lot of pictures here of echogenic material inside the vein, no flow, no collapse. So you can sort of see a pattern here. There's a bit of a smoking gun. Echogenic material, this one even has an asterisk inside of it. I mean, how obvious we need to be, right? And it doesn't fully collapse. So, a good friend of mine actually wrote a book called Do No Harm. It's not the most unique title, but it's a good book. So when I'm thinking about all this putting pressure on veins that already have an obvious clot, right? When I see a clot inside a vein, I've made the diagnosis of DVT. Thank you for remembering the title. Well, actually, I guess the title was Scan This. But anyway, the point is, that's what we're looking for. Right? So you can stop. You can stop. And here's why you might want to stop. Because, you know, the question comes up every now and then, if I squish that vein, am I going to flick off clot and send it places, you know, clots really don't belong anywhere, but at least when it's in the leg, it's kind of a safe-ish area. So, Dr. Medipore and a bunch of others looked at 3,600 articles in the existing PubMed literature, and they found 7 cases, and confirmed and one probable, that 2 of which were fatal, where it was demonstrated that, you know, they looked at a clot, and then the patient has a pulmonary embolism, and they look at the clot again, and it's not there anymore, right? So, so this is not a high number, but it exists. It exists, right? So it's probably something that can happen pretty infrequently, but it's out there, so just be cautious. So keep in mind also that ultrasound exists within the larger scope of your clinical acumen and your flow in your department and the overall patient management, right? So just because you can do an ultrasound is very important, but it's not the only thing you're going to do. You're still going to start. There was a great review article that just came out, which will be in the handouts or notes from this. Western Journal of Emergency Medicine just this year, 2016, you know, did a nice reevaluation of the existing literature on this, and they recommend starting off with pretest probability and a Wells score, incorporating the D-dimer, and then doing a lower extremity clinical ultrasound. And if it's positive, you have to coagulate the patient. If it's negative, they follow up within either a couple of days or a week for a repeat ultrasound, because clot can propagate and you can miss things. So that's a pretty standard follow-up for your patients. It still remains true that if you do point-of-care sonography, as I was describing, and the patient has a negative sonogram, you can safely discharge them, but their follow-up is important. okay? You don't want to be another one of those case reports. You can't base your management around a case report, but it's a known thing that clots can grow and expand and propagate. So if you miss it, they come back for follow-up later on. So that's it. Hopefully you can incorporate DVT ultrasound into your practice, or maybe there's a couple of tips about looking for DVT that'll help you in your venous access cases. The ultrasound division website at Sinai's got tutorials, including a talk on this, I think, and some other information on the website. And again, I'm available on Twitter. Thank you very much.